Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and a writer that's been working with CCF for 10 years. In fact, Grace Goldstein, the COO, just this past week, she randomly saw the email when we first decided to choose me among some others to work with. So in fact, it has been a decade, and that has been one of the best, most profoundly impactful projects and relationships that I've had in the past decade for my career and for my personal life. I appreciate you all welcoming me to the NET community, and all the video content that we produce is with the same mission in mind, and that's to educate people and spread awareness about this disease. So if you are new to the show, I want to say welcome. I highly encourage you to introduce yourself to the community. They will embrace you. They will help you. And if you are a regular, which it seems like we have a lot in the room already, you're saying hello, you're telling people where you're from, and starting to spread some of that community love. Hi from Western North Carolina. Nancy, where are you from? I'm here in Durham, so we're probably not too terribly far away, although North Carolina is like this, so Western North Carolina can be far away from Central. Before we get started, we always want to thank our sponsor, Ipsen Biopharmaceuticals, because without their support, we wouldn't be able to do the show. And we have this disclaimer from them, and that is that the opinions expressed by our guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. So audience members should not rely solely on the opinions or information expressed by our guest, and should seek guidance and direction regarding from their own medical advisors regarding any choices they make about their health or treatments. So that last line is really the takeaway. I'll reiterate it. We're going to give you some good advice today, some answers to your question, but by no means do we or our guests know your specific case unless they are your doctor. So take that advice, take those answers back to your home team, which does know your specific case, and make the best plan and path forward for you. If we know anything about this disease, it's that each case essentially is unique, and therefore each plan and path forward is as well. So we highly encourage you to do that. And I also will ask, we can't really get too case specific with the questions, so try to formulate your questions in a general way so that you're still getting a lot of value out of them. Our guest has been here before today. I promise you he is going to take care of you. So I would like to welcome our guest, Dr. Thorvardur Halfdanarson. Did I say that right?
That's pretty good.
Pretty good. We know him here in the States as Thor, although that might make you cringe when you're used to it being Thor. How do you like it to be pronounced?
So Thor actually is pretty good for Icelandic.
Okay, for Icelandic, that's right. Okay, a lot of my friends are from Norway and Sweden, so that's where I get my
always Thor there.
Yeah, it is. All right, so welcome to the show, Dr. Halfdanarson. Tell the folks at home that may not know you or be familiar with your work what you do in the NET community.
Sure. So my name is Thor Halfdanarson. I'm a medical oncologist and what's called a GI oncologist. So I specialize in tumors of the intestines, essentially. But I also see patients with neuroendocrine tumors, which is probably most of what I do now. Probably 70-80% of what I do is neuroendocrine tumors, and not just of the GI tract. I see patients with neuroendocrine tumors of all possible origins. High grade, low grade, localized, advanced, lungs, intestines, really wherever they might arise. So as a medical oncologist, we think of ourselves as the people who give chemotherapy, but we also do a lot of other things as well. So in terms of surveillance after surgery, follow people on other treatments than chemotherapy, and so on and so forth. And then I'm actually very involved in clinical research as well in neuroendocrine tumors.
Got it. Okay, great to know. So folks, go ahead and start sending in your question. Dr. Halfdanarson, I see from Bridget. Hi, Dr. Thor. He is my doc. See some of your patients in the room already. So folks, go ahead and start sending in your questions. Wow, we have already shot up over 100 people in the room. Dr. Halfdanarson, your reputation apparently precedes you, my friend. That is very good indeed. And we are only 6 minutes in. So folks, here's what we're going to do. Go ahead and start sending in your questions. Dr. Halfdanarson has kind of established and given you a baseline of where his specialties lie, which are kind of vast. So I think that any question is fair game. Go ahead and send them in, and I will just let you know that the video will live evergreen here on the Facebook page. Starting Monday, we'll publish it to YouTube. So I say that to say you can always replay the video if you missed something, or if you want to go back and revisit it, it's going to be here for you, I promise. But the real value, I think, is to be able to ask a question that you or your home team may have been struggling with. So that's what we're going to try to do today. If you know someone who would benefit from being here and having that interactive one-on-one session, tag them in the comments, share the video, let them know that this is going on. And the more people here that we can get here, the more people that we can help. Now, inevitably, we get so many questions every episode that we can't get to them all. So if that happens, or if you have a follow-up question, I encourage you to do a couple of things. One, reach out to CCF either here on the Facebook page or at carcinoid.org. That's their website right behind me. And also tune in every week. We're here every week with different specialists with different backgrounds. And if you want to go back in time, we have a database. We've been doing the show a year and a half now or more, a little bit more. So we've got a lot of episodes that are available to you. And I alluded earlier to some of the work that I've done with CCF as a filmmaker. We have patient-centric stories. We have treatment-based videos. There is a humongous library of video content that we have provided for you. And I can't promise you, but I'm very, very confident that the answer to your questions is out there. So our job is to help you find those answers. And so if we don't get to it in the next 52 minutes, we will do everything that we can to get to it. Okay, so go ahead and start sending in your questions. Say hello to everybody else if you haven't already. One final thing I like to ask you all every week, and you do a great job of this, is if you see a question in the sidebar of the comments that you also have, or you're interested in the answer to, you can simply, right under the question, there's the ability to like it. And if you hover over that, it gives you a lot of emojis you can use. They all work the same for me, and that's just to upvote that question. If I see there's a big demand, 9 people have the same question, I'm going to make sure that I get that one across. Like I said earlier, we get so many, we can't get to them all. So that effectively upvotes that question, and I'll know that we need to ask it. So Dr. Halfdanarson, you said now that you're about at 70 to 80% of your patients are net patients. Is that accurate?
Yep, that's accurate.
Okay, so you started, you work in the GI tract. Do you remember, well, let's pinpoint it down a little bit. Do you remember your first net patient case?
Not necessarily the very first one, but sort of the first few I saw as a fellow, and we're going back to 2003. Actually, I do remember my very first net patient, now that you say it, when I was a medical student in Iceland, and someone who had a small bowel during tumor with liver metastases and with carcinoid syndrome and a lot of flushing. So that actually I remember vividly. That's probably the first one I ever saw, and that must have been in the early 90s.
Okay, and so do you, and were you familiar with, with that term? Did you know what to do at that point? And if not, how did you find the path forward?
So back then, so I think a lot of oncologists sort of considered these not to be malignant, barely to be cancers. So I remember I was told that, yeah, this is a carcinoid tumor, and it's some say it's not cancer. We really don't have anything that works for this. This is before we routinely were using somatostatin analogs. So I remember it was just an interesting thing being faced with this malignancy and being told that most people don't really know much about it and there's not much that can be done. This is close to 30 years ago.
Yeah. And at what point did net patients become the predominant percentage of your patients, or what, to walk us through that journey from that first one?
So, so I came to the US in 2000 to do my residency at the University of Iowa that had a neuroendocrine tumor program. At that time, I didn't really know I was going to specialize in this, but my first attending there on my very first day was Dr. Tom Odoricio, who just passed away a couple of weeks ago. And he showed me, introduced me to the net world. And I didn't really think I would end up there. So I did a lot of other things in training. And then finally, as a fellow at Mayo in 2005, I started getting into really heavily into pancreatic neuroendocrine tumor research. And initially, I sort of just looking at projects and had seen a few patients. I didn't really find a whole lot of literature. So my first project was really just to see how people do with these tumors in a large database. So that's, and then you could say it's spun out of control from there.
Yeah. All right, well, we're having a lot of questions come in already. Like I said, our numbers are really great. We're over 120 now. So I'm going to go ahead and start taking questions from the audience so that we don't miss very many. So, oh, and I see our friend Cade says, just stopping by to say hello this week, can't stay. All right, Cade, good to see your name. And please know that you can replay the video later. Okay. Simran says, hi, I just had Y90 on the right side of my liver 3 weeks ago, but I'm having abdominal pain. Any idea why?
Yeah, so with the, what's called liver-directed therapy or embolization therapy, there can sometimes be some irritation as the tumors die from the embolization, be it with chemo embolization or Y90 liver embolization. So it could just be some irritation from the treatment. It's very common to see that if it is severe, especially if there is like fever and the abdomen is really tender to touch, probably a good idea to call your provider, go in. You might need to get some imaging, but it's actually not uncommon to have some pain afterwards.
Got it. Thank you for that. Bernadette says, I'm 12 years NED of lung, and I am always told I can come back. What symptoms are there to keep an eye out for a lung net?
Yeah, so here with a lung net, we have to know was it like what's called a typical lung neuron tumor, or was it a really low grade? If they are resected and they're not involving the lymph nodes, they almost never come back. Mm-hmm. And for the slightly more aggressive atypical lung nets, they can come back, and they often come back in the lungs, but we're actually seeing them increasingly coming back in the liver. And so any abdominal symptoms, weight loss, any unexplained symptoms of flushing, diarrhea, weight loss, anything that's out of the ordinary should prompt an evaluation and possibly a CT scan. So I would typically follow people at higher risk with CT of the chest, abdomen, and pelvis, maybe annually for a few years and every other year for a few more years.
Got it. Still in the lung net space, Melinda says, what does it mean when a lung nodule has changed by 2 millimeters and shown uptake in the last gallium scan? Is this a reason for concern?
So another great question. So lung nodules, if you just look at the size, they can vary a little bit in size from one scan to the next. And think about the lung nodules, they are like little spears, and sometimes when you do the CT scan, you cut right through the equator of the globe, the little lung nodule, then it looks larger. If you if the CT slice is a little above or below the equator of the lung nodule, it appears a little bit smaller. So if it's growing across 2 or 3 scans, I'd get worried. Not everything that lights up on gallium or copper dotatate scans is neuroendocrine tumor. Sometimes inflammation can light up faintly. So I would just follow this with another CT scan. And if we have 2 or 3 CT scans in a row, each showing slight enlargement, that's when I start getting a little more worried. But a 1 to 2 millimeter change from scan to scan typically doesn't upset me much.
Got it. Okay, from Dana, good morning. How aggressively should a patient be looking into debulking surgery? We've been told that surgery isn't even on the radar right now since the response to Rheotide has been very positive. But I can't help but think that debulking, I just lost the question. So did you catch the first part of that question?
I did, actually.
Okay.
So, and this is probably one of the the most debated things in neuroendocrine oncology. So debulking, essentially trying to remove as much tumor as possible.
Right.
And when we talk about debulking, we're usually talking about liver debulking, trying to remove liver metastases. So we know once you have liver metastases from neuroendocrine tumors, such as small bowel neuroendocrine tumors or pancreatic neuroendocrine tumors, there are probably many small liver metastases that you can't see. So if you take what seems to be healthy liver, you look at it carefully in the microscope, you'll find tiny little islands of tumor cells in many of these patients, especially with the small bowel neuroendocrine tumors. But what we always, the way we think about this is that if this can safely be done with surgery or embolization or ablation, we could possibly set back the clock, even by a few years. This is still pretty debated, but at Mayo, for example, if the liver tumors look somewhat limited, I always ask my surgeon to weigh in, either in person or at tumor board, and ask them, would you consider this person for liver debulking? And I would say that quite a few of our patients who come to us being told that liver surgery is not an option end up having liver surgery at Mayo. And the question is, how much does this prolong life? We just don't know. data would suggest that if you take more than 80 or 90% of the liver tumors out, you might actually see some improvement in life expectancy.
Got it. Kind of a bigger question, but we've had some variation of this before. Alyssa says, are you seeing an increase in NETs as compared to a few years ago? And if so, why?
Yeah, great question. So absolutely, we're definitely seeing an increase in NETs of all types: lung NETs, pancreatic NETs, small bowel NETs, rectal NETs, stomach NETs. Everything is going up. I think a lot of it has to do with what we call incidental findings. So now we're doing a lot of routine colonoscopies. So we're people getting screened for colon cancer, and yes, there's a small polyp in the rectum. It turns out to be a NET. There's a good chance that person might have lived their entire life without knowing this. Yeah. So same thing with pancreatic NETs, and we will have a paper coming out on this very soon. We looked at a large database in the US. We've seen threefold increase in pancreatic NETs in the last 20 years, and almost all of it is accounted for by localized pancreatic neuroendocrine tumors. And I think this is mostly people going in with abdominal pain, going to the emergency room with a kidney stone, or going to the emergency room after having had a car accident, and they have a CT scan, and yes, there's a neuroendocrine tumor there. So it's not like people are presenting much with these symptoms. We're just finding them incidentally. I think that explains a lot of it. But even after accounting for that, I think there's a real increase, and I don't know why it is.
Got it. Well, thanks, Alyssa. Hopefully that helps. And I just want to go back to something you said earlier. Someone else in the comments had said, sending love to Dr. O. We mentioned Dr. Tom Motoricio, who is a friend of the foundation. He's been on the show several times, a friend of mine as well. I've worked with him multiple times. And I just wanted to pause for a moment again and send some special love out to him and his wife, Dr. Sue Motoricio. Very, very great people in the world, and specifically in the NET community. So we really, really think fondly of him over here. Moving forward, we're getting a lot of questions about lung NETs, which is interesting. I know that we have a lot in the audience that have lung NETs. Ellie says, I had a low-grade NET removed from my lung. Is this something that I will have to follow up with the rest of my life?
Yeah, so it's a good question. So if it's what's called a typical lung carcinoid, and keep in mind that the terminology for the lung NETs is a little different. They still are called them carcinoids in the lungs. And if it's what's called a typical carcinoid, very low grade, small, no lymph nodes, the chances of that coming back in the next 10 years are probably less than 10 to 15%. So you could actually make an argument for not following at all, but it all depends on the size of the tumor and the tumor grade. So I'd say, as a rule of thumb, I would probably follow most people after surgery. I would follow them with at least with chest imaging of some sort, typically CT.
Thank you. Shifting gears a little bit to PRRT, another very common topic on the show. David says, I had PRRT in 2021, which stopped tumor growth. Great to hear, David. Would a second series of treatments be effective if and when tumor growth resumes?
Yes. So the answer is probably yes. So we don't really have a great trials yet. We'll hopefully see. And actually, there will be a trial opening, I think, soon, looking at what's called PRRT retreatment. Mm-hmm. But we have lots of data from the Netherlands, now some data from Denmark, and some data actually emerging from the US, that if you treat with PRRT after progression, after the first PRRT, there's some benefit. It's probably a little bit less than with the first PRRT in terms of like time until progression. Mm-hmm. And the way we do this at Mayo, we follow the Netherlands protocol. We say, well, if you got more than 12 months from your last PRRT or more than 18 months from your first PRRT before tumors grew, we'll consider retreating again. And we typically retreat with 2 retreatments. So we probably retreated 30 or 40 patients at Mayo already, and we're soon going to be looking at their outcomes. But definitely a role.
Got it. Thank you. Gail says, when will the next radioactive treatments become available? My husband has a small intestine NET with liver metastases.
Yeah, so the next generation of PRRT, what everyone is looking at right now is alpha particle therapy. So
Exactly.
I know it's exciting and it's sort of a new shiny thing, and it's very exciting. But I think that we could also improve upon the current PRRT with lutetium-177. There are studies now looking at combining that with chemotherapy, possibly combining that with other treatments. So that's actually on the horizon. But really, the alpha particle therapies are what we're all looking at. This is a more powerful radiation that travels less distance, potentially more effective, potentially less toxic. That all remains to be seen, but early data from the US, from India, and from Europe actually look promising. And I think we'll see the first large trials in alpha particle therapy in the US this year. So there are a couple of trials hopefully opening soon.
Got it. Good to hear. Good to hear. From Rena, is a rectal polyp that pathology was carcinoid considered a tumor? And what sort of follow-up is recommended after it is removed?
Yeah, so that's actually an increasingly common problem and something we don't see in my clinic much, because now the gastroenterology is actually taking care of most of them. So most rectal neuroendocrine tumors are small, and most of them are low grade, either grade 1 or low grade 2. And if they are completely removed with colonoscopy, typically a colonoscopy 6 to 12 months later, just to see if there's anything that remains there. Occasionally you have to do what's called endoscopic ultrasound. Typically just follow up with the colonoscopy if it's a low grade small tumors. Typically, scans are not needed. Gallium scans or copper scans are not needed. Markers are not needed. But it all depends on the size of the tumor and the tumor grade. These are really the key things.
Got it. Next question from Jeff. Now that Moffitt has shown a slight increase in myelodysplastic syndrome in those patients on CAPTEM, followed by PRRT, does it make sense for those patients to have subsequent rounds of PRRT after the initial 4 cycles?
Great question. So the big concern with myelodysplasia, which I think of as a form of leukemia. So it evolves into leukemia. It's a very, very difficult disease to treat when it happens. So we know from that first study led by the Moffitt team, by Dr. Strasberg, the study called NETTER-1 that you may have heard of, that they finally reported the long-term outcomes of that late last year, just a few months ago. And the MDS and the AML, the acute myeloid leukemia and the myelodysplastic syndromes, they were actually less common than I expected, which is great, under 2%. But if we combine PRRT with chemotherapy, CAPTEM or other chemotherapy, or give CAPTEM before or after, we probably increase the risk. And there are some data coming out of Australia saying that this may increase the risk as high as 5 to 7, 8%. But that said, we always have to weigh that risk against the benefit of doing the PRRT. Sometimes there just isn't another good option for therapy, and a small risk of AML or MDS can be justified by the big benefits of doing PRRT. So it's always a risk-benefit ratio. Hopefully, eventually we'll have some blood tests that can predict who is at more risk of getting AML or MDS. We don't have that yet. But yes, risk may be increased, but sometimes it may be worth taking.
Got it. Thanks, and Dr. Halfdanarson, and thank you, Jeff, for your question. Folks, if you're just joining us or joined us a little bit late, this is Carcinoid Cancer Foundation program, Luncheon with the Experts. We are here with Dr. Thor Halfdanarson, and we're already covering a lot of ground, a lot of great questions, and a big audience with us today. Someone said, Dr. Halfdanarson, that I can't see it now, but they just said they love how you answer questions. There's like no hesitation. I noticed that as well. So a man who knows his work. Sharon says, does Dr. Thor practice ACC? I'm unfamiliar with that acronym. Could you help me?
Yes, actually I do. So ACC is a malignant tumor of the adrenal gland called adrenocortical carcinoma. I think that's the ACC I know. So this is something I used to do when I was at the University of Iowa and at Mayo in Arizona. I actually stopped doing this for a number of years when I came back to Rochester, but as of last year, I'm actually starting to see patients with ACC again. So I said 70-80% of what I do is neuroendocrine tumors. I do a little bit of endocrine therapy, so pheochromocytoma, paraganglioma,
Mm-hmm.
aggressive thyroid cancer, and ACCs. So I do still see ACCs.
All right, Sharon, if you have a follow-up question, a little more specific, let us know. We will be here. Moving forward, well, this is a kind of a follow-up question to the, are we seeing more people or more NET patients, more cases of neuroendocrine tumors? Simran says, are you seeing more youngsters with NETs, more children?
Not really, not more. So we occasionally see people in their, even in late teenage years, 20s and 30s, but I will admit I don't know if anyone has really looked at this particular cohort of patients, but my sense is that we're not seeing more, and but they are obviously being picked up because they have scans for other reasons. I don't think there's a major increase, but we see a fair bit. So I've seen people in there like as young as 14 or 15.
Yeah, for sure. We've done some short documentaries and videos on some children that have had NETs, and I think historically, at least, I think people misunderstood it as something that typically only people 50 plus would get. But I am seeing, just anecdotally, but from the stories that we tell, a lot of younger people, 20s and 30s and 40s, and then certainly some cases of children as well. So, okay. Thanks for your question, Simran. From Esther, none of my NETs have ever shown on any scan. We hear this problem a lot too. CT, MRI, gallium-68. What is the best way to monitor going forward? Biochemical, NET test, anything new on the horizon for this? And as a secondary question, also, can you have carcinoid syndrome before it shows up on blood work? We get similar questions to that second question as well.
So if nothing, so I think it's a great question. So if you have, it's very unusual to have an active neuroendocrine tumor and nothing showing up on scans. So modern day CT scans and MRIs and the PET scans pick up almost all of them. That said, you can have a very small amount of neuroendocrine tumor cells hiding, possibly sort of in multiple different small locations in the liver, and that could possibly cause you symptoms.
Okay.
But a lot of neuroendocrine tumor symptoms in someone with no evidence of neuroendocrine tumor on scans would really make me think, is there something else causing these symptoms? Are we missing something else that's not a neuroendocrine tumor? Because we always have to keep that in mind. As for the blood tests, the conventional classic tumor markers, chromogranin and 5-HIA and others are not perfect, and they are not very specific, so they pick up other things than neuroendocrine tumors. And then there are some people with very active neuroendocrine tumors, and these blood tests are completely normal, so we can't rely on those. NET test seems to be the best performing neuroendocrine tumor, probably not perfect either, but I am actually starting to use NET test to follow patients after surgery. So I do a NET test after surgery, and I do it with some frequency for the first few years. So I only started doing this last year. We finally have the data, I think, convincing data to consider using it after surgery.
Yeah, that's interesting. And I know that controversial is not the right word, I don't think, but the NET test was, once it came out, was highly discussed and debated, and people understanding it. So it's good to see there's some data now, but I didn't know that it was being used on the back end to follow up as well.
I might be an outlier there with the NET test. I've been watching this with a lot of interest for a long time, but I was just always thinking, how can I use it in my clinic?
Yeah.
So because a lot of my patients have the neuroendocrine tumors, I can see them on the scans, and so I didn't really need another blood test for most of them. But for post-operative surveillance, and this is just a thought. This is not a recommendation. So I'm thinking if the NET test lives up to expectations, and it's starting to look pretty good, and I have no connection with that company whatsoever.
Sure.
If it lives up to these expectations and continues to look as good as it does, could we maybe in the future rely more on the NET test and rely less on scans for after surgery? Wouldn't it be great if we could switch the scans out for a reliable blood test?
Very
I think we have some
interesting.
initial data suggesting that maybe in the future.
That's very interesting. All right, folks, we get a lot of questions about the NET test, obviously, and we've been doing the show almost 2 years now. So the thoughts have changed. I know initially people, I think it's just people don't want to speak about something if they don't have all the data. It wasn't really controversial. It was just like it was new to a lot of the doctors and specialists, and they didn't have enough information to really base a real opinion on. But folks, our very first episode of Luncheon with the Experts, and I find myself saying this more and more every week, was with Dr. Modlin, who created the NET test. And so if you're interested in learning about it, look no further than that episode. It was all about the NET test and from the guy who created it or one of the team members who did. So I would suggest going back to that. And again, that was in July of what year are we in now? 2022, 2020, I guess. It was a while back. So I'm sure things have changed with that too, but that would be a good place to start getting information. But this is Dr. Halfdanarson. This is exciting, exciting stuff that you just told us about it. So I appreciate you sharing that. Okay. From Nancy, is there any correlation between GI net and kidney damage?
So not directly, no. So kidney damage can obviously have a lot of different causes, diabetes and high blood pressure being the most common. So I'd say the vast majority of my patients with neuroendocrine tumors who have kidney damage have another cause for the kidney damage. So that said, there is with older PRRT, especially with the old yttrium-90 PRRT, there was probably 5 to 10% chance of substantial kidney injury. And with some chemotherapies, not much used today, like streptozotocin and some others, there is some risk. But as for clear association with neuroendocrine tumors and kidney damage, probably very unlikely.
Got it. Thank you. Another lung net question from KR, and this is an interesting or unique one. I have lung nets, and my lungs are damaged from COVID. So what can be done other than surgery?
Yeah, so here it's all about what these, how many are they, and are they changing? So we're seeing a lot of people with the long-term consequences of COVID now, neuroendocrine tumor patients and others. And obviously, if there is impairment of lung function, we don't want to go in there and remove a third of a lung, and that might leave that person even more short of breath than they already are. So I'd say the first question is really, do we have to treat? And if they are many and slowly growing, drugs like octreotide or lanreotide or everolimus or Afinitor might be considered, or oftentimes we just wait. And if one or two are growing out of proportion to the others, we could do things like ablation, stick a needle into them and burn them or freeze them where they are, or do what's called the stereotactic body radiation therapy, very, very targeted radiation therapy to just that and try to spare as much lung as possible. So this really needs what we call a multidisciplinary evaluation, a tumor board.
Let's go back to the NET test really quickly. I've seen a couple of questions come in after we chatted about that for a bit. Let's lay down a little bit of like foundation for what that is. I know we've said it's a blood test, but I had a couple of people just saying like, what exactly is that? Is that a PET scan? You know, like, can we just give a simple like, what is the NET test?
Yeah, so the NET test is actually looks at it's called a transcriptomic assay. So it looks at the products of certain genes that are related to neuroendocrine tumors. I think that's probably the best way of thinking about it. There are certain genes that are strongly associated with neuroendocrine tumors. And the test is looking at products or evidence or fingerprints of these genes, if you will, so essentially like trace amount of neuroendocrine tumor in the blood. And it's by picking up what's called the mRNA. And this could be apparent way before we see anything on scans. So it's a very sensitive, kind of like a genetic test, unlike any other marker we have. And so lots of potential, lots of data now. And we just have to figure out, where does this fit into our sort of clinic routine?
Yeah, absolutely. That is.
Not sure if Dr. Modlin would be satisfied with this explanation of the NET test. It always sounds much, much better when he says it.
I think it was very well done, sir. But to follow up with what Dr. Halfdanarson said, I'll reiterate that the first episode of Luncheon with the Experts that we did was with Dr. Maudlin. And so if you want, for those asking, hopefully that helped. But if you want more information, deeper information about it, that is the episode to go to. And you can simply go to the videos tab on our Facebook page, scroll all the way to the beginning of Luncheon with the Experts. Again, that was July of 2 years ago. So there's a lot. There's, we do this every week, so you can you can do the math. Okay, let's move on. We've got a little less than 30 minutes. I will just say that Kathy, a +1 to this. Great explanations and answers, clear and easy to understand for the layperson, and I totally agree with that. So thank you, Dr. Halfdanarson.
My pleasure.
Gail says, my husband is currently on Afinitor for his carcinoid liver metastases. He has increased blood sugar. Is this a normal side effect? And if so, how much of a concern is it?
Yeah.
And I just wanted to also mention Dr. Halfdanarson is his oncologist, for which we are grateful.
Oh, thank you. Thank you very much. So no, so this is actually one of the most common side effects of Afinitor or everolimus is high blood sugar. So it has some other side effects like mouth sores and things like that. Typically, most people can stay on it, but many will need some dose reduction. If the high blood sugar is the only thing, the only major side effect, I treat that as diabetes. So sometimes I'm not really good at managing diabetes anymore. So a lot of times I will actually refer people to the diabetes team at Mayo, or just tell them to work with their local primary care provider. And many of them are just so good at managing diabetes. All I need to tell them is treat this like diabetes. If it's outrageously high, as it occasionally is, then we will have to lower the dose.
Got it. You alluded to a moment ago about the importance of a tumor board, of a multidisciplinary team. Can we go back to that a little bit? And it seems to me on the show today that we might have people that are new to this journey. We typically have people all across the spectrum, very well educated people who have been dealing with this for a while, and they really know their stuff and ask thought-provoking questions. And then sometimes people that got diagnosed this week, and they're scared and concerned and looking where to turn, and they find our show, which is great. So for them, I always like to lay some groundwork. We talk often. We've made videos about multidisciplinary teams, but let's do some, again, kind of lay some foundation. What exactly is that? Why is it so important to this disease specifically?
Exactly. And here I will say that my opinions on this actually differ from a lot of those in Europe and some in the US. So let's first explain a tumor board. So tumor board is a meeting which in this pandemic has been mostly virtual on Zoom, actually works beautifully on Zoom, and even in some ways better. And so in a virtual or a real room, we have multiple surgeons, medical oncologists, radiologists, nuclear medicine physicians, pathologists, sometimes gastroenterologists, and even endocrinologists if needed. We call in those additional people as needed through interventional radiology. So when we present cases with challenging decision making. So let's say someone has a neuroendocrine tumor with liver metastases, or a complicated pancreatic neuroendocrine tumor that has wrapped itself around some blood vessels. And we sit down and the surgeons weigh in. Should we do surgery? If we do so, should we do chemotherapy first? The pathologist says, well, this is what it looks like in the pathology. So this, for patients with complicated decision making, is absolutely crucial. I can't state that often enough how important this is. But if you think about it, for example, we see about 500 new neuroendocrine tumor patients per year at Mayo, and probably about 400 of them are seen by the same 3 people. So Dr. Uptake, my colleague, Rachel Eyring, our PA, who's phenomenal, and so is Dr. Uptake, and myself. And we see hundreds of new patients every year. So a lot of patients we see, they don't need a tumor board because we do this all the time. And I'm very quick at seeing, and all of us are very quick seeing, well, this person needs to go to the tumor board, this person doesn't. So in some of the European centers, they say we should present every patient at tumor board. That is not needed, in my opinion. You need to present the people who truly need it. But if your oncologist doesn't see a lot of neuroendocrine tumors, it makes sense in that setting to present them all at a tumor board. Does that make sense?
It does to me. Yeah, it does to me. folks, if that sparked any other questions, you know that you can ask
I
him.
love my tumor board. That's I couldn't function without it, but I use it selectively.
Yeah, that makes sense. I mean, that definitely makes sense. And I think most people really lean on that and leverage and utilize that tumor board because each case of this disease is specific and unique.
And I will tell you about this thing that many of us do, which I sometimes call the mini tumor board. I see someone who is like has a neuroendocrine tumor and I need some input, but not from the entire group. Then I connect with the healthcare, the electronic medical record. I contact maybe one surgeon and the pathologist, say, can you please take a look at this for me and let me know I'm on the right track. So that's what we do, that all the time, multiple times a day.
I think it's very necessary. It's very necessary. And I see that willingness, that lack of ego consistently through the NET community in terms of specialists and doctors. I mean, people really are in it to find the best answers for each patient. And I think that is echoed throughout the community. And I think the patients see that as well. It's very apparent and they respond to it. I've said this many, many times, whether it's the patients, the caregivers, support group leaders, and the doctors and specialists, it's a very strong community, very supportive community. And I can't speak to other cancers and if they are that way, but it's evident with the NET community. And that's something that's very powerful. From Kaya, I hope I'm pronouncing that correctly. Is there a reason to start Sandostatin / Rheotide if not flushing and diarrhea and currently several 1 centimeter metastases?
Not always, no. So if there are no symptoms, it's a low-grade tumor and it's what we call low tumor burden, you don't have to. And this week I saw a person in exactly that situation, no symptoms, small liver tumors, they light up on scans, I can see them, but they haven't really changed. We're going to leave them be. I have a few patients in my clinic I've been following for a few years. We've never started anything. And the tumors in the course of maybe 2 to 3 years have grown by a few millimeters, and they're still small. We haven't started anything yet. So sometimes it's appropriate, but be careful if you decide to do that. Follow people carefully, do a scan maybe a little sooner than you otherwise would have. Just make sure that this is not like getting out of control.
Great. Thank you for that. And thanks for your question. Kaya, if that's how you pronounce your name, just I've seen you comment a couple of times. Just let me know if I'm saying that correctly. That's important to me. Okay, Richard, diagnosed 4.5 years ago, primary duodenum, multiple mets to the liver. A recent MRI shows an enlarged lymph node of 1.6 centimeters superior to the pancreatic head. Is this of great concern?
So it may not be. So what we would then, we look at sort of the proximity to blood vessels and bile ducts, and we look at the bilirubin and other blood work. And if nothing is changing, and it's a relatively small lymph node metastasis, sometimes we just observe this. Occasionally, if it's in a critical location, I take this to tumor board and ask the surgeon, it is worth going in there trying to remove this if we can't really do any of these other tumors, or could we maybe radiate? I actually think radiation therapy is underutilized in neuroendocrine tumors. And let's say if there's one trouble spot that might start pushing on other organs or pinch off blood vessels or bile ducts, sometimes we actually decide to radiate that before it becomes a major problem.
Got it. Thanks, Richard. Hopefully that helped. Our friend Marnie, what treatment should be considered for a large 15 centimeter complicated PNET that has involvement of several blood vessels?
Yeah, so these are really, really challenging. And here is where we are actually using what's called neoadjuvant therapy. We start chemotherapy often with capecitabine temozolomide, or CAPTEM as some know it, and try to shrink the tumors down to a more manageable size. Some of these tumors are just so wrapped around so many critical blood vessels that we know even from the get-go that we're probably never going to get them out. And so then what I do is to try to shrink them down with chemotherapy. And if they get to a more manageable size and the surgeon says, no, I still can't do it, there's no way I can do this, then we consider radiation treatment. But what is changing here, and this is something that is actually very important, is that there are now some pancreatic surgeons who are increasingly doing what's called vascular reconstruction. So this is actually cutting through these blood vessels, putting a graft in between, or rerouting the blood vessels. And we have a few of them at Mayo. Dr. Mark Trudy is one of our surgeons, has been leading this effort at Mayo for many years now. So I'd say before we call this completely unresectable, these patients should all be seen at a large medical center that specializes in what we call complex pancreatic surgery. All pancreatic surgery is complex, but this is like super complex pancreatic surgery.
Yeah, fair. Okay, thanks, Marty. Good to see your name again. Hopefully that helped. Okay, here's a toss-up one for you, Dr. Halfdanarson. Marianne says, who manages lung nets at Mayo?
Oh, that's a great question. So it depends. So if someone calls in and doesn't request the Neuroendocrine Tumor Clinic, myself, Uptake, or then it goes to the lung cancer group, and there we have people who are truly interested in this. Kostas Levantakos, Aaron Mansfield, and some others. So they are lung cancer oncologists, but they've been working on neuroendocrine tumors as well. They're not nearly as well known in the NET community. Mm-hmm. Because most of the time they live within the lung cancer community, right. The lung cancer community, but they are really good at what they do.
Yeah, isn't this, correct me if I'm wrong, and I may be wrong, of course, I'm not a medical expert, but isn't this kind of how we're approaching lung nets, where we're not exactly sure whether it's a lung cancer doctor or a net specialist that handles, and sometimes it's a kind of a partnership. Is that accurate to say?
That's actually very accurate. Okay. So I would say probably the majority of lung net patients are seen by lung cancer specialists, and who are doing a really good job. Mm-hmm. So I think with the lung, it's always at some point getting the thoracic surgeons and sometimes even the radiation oncologists. I think lung nets really a lot of times require tumor board discussions, and that's actually what our lung cancer group does so well. They have such frequent tumor boards. Yeah. They present a lot of these cases at tumor boards.
Folks in the audience, I forget what that commercial was, a while back, but you remember the saying, there's an app for that, whatever that was. Someone can tell me in the comments, but I know I've been saying the same thing throughout the whole show today, but if whatever the topic is, I can almost guarantee you there's a video for that. And so I say that to say we had one on lung nets, and it was featured Dr. Robert Ramirez, who is popular in the lung net community. And so we have a video about that. Obviously this disease changes and we learn more about it every year. But that's a video that's specifically dedicated to that. So you can learn a little bit more about that, because this is a common issue that we face. Is it a lung cancer? Is it a net? Kind of both, so I was just interested in that question. Thank you, Dr. Halfdanarson, for fielding it. You mentioned tumor board again, and I have a question about a tumor board from Michael. Would I even know if there was a tumor board established for my case?
You probably wouldn't, and I think it's a fair question to ask your oncologist. And I would just say ask. So, is this a situation that should be discussed at the tumor board? And sometimes my patients ask me, "Did you discuss this at tumor board?" And there are times I say, "No, actually, I don't think we have to, but I'm happy to do it." And there are others where I say, "Yeah, absolutely, this has to be discussed." We just had tumor board this morning, so there are always some cases with of neuroendocrine tumors there.
Got it. And update everybody, just because I'm proud of myself, Kaya is exactly the right pronunciation. So I did that right. From Christy, is Rheotide ever used on higher grade net patients?
So yeah, well, that's a good question. So I look at Rheotide and octreotide as equally effective drugs. Rheotide is just in some ways easier to inject. It doesn't have to go into the muscle, and it can be injected under the skin, and that's much easier for the nurses. So octreotide may have to get has to go deep into muscle, and that's a challenging injection, especially if you're not really experienced with this. And so for high-grade tumors, then now the question is all about what's called differentiation. If it's a well-differentiated grade 3 neuroendocrine tumor with Ki-67 less than 50, it's reasonable to try it. And it doesn't control it for very long, but sometimes for many, many months. And we actually have a study coming out on exactly that, hopefully soon. And if it's a poorly differentiated high-grade neuroendocrine tumor, like a small cell or a large cell neuroendocrine carcinoma, no, I would not use Rheotide or Uptake. It's not going to work. And neither is PRRT. Not for the poorly differentiated.
Thank you, folks. We've got just shy of 10 minutes left, but great questions. We're going to keep on trying to answer as many as possible. Janace, I believe, how soon after PRRT can Rheotide be given? And then the real question is the same day okay?
4 hours.
That sounds like it falls in the same day.
That's how we do it. That's how we do it here. So all of my workers say Rheotide or Octreotide if the person is on that. We give 4 hours after the PRRT infusion. So realistically, it ends up being close to like 5 to 6 hours, just because it takes time to get from one part of the hospital to another. So, but after 4 hours after the infusion, we're good.
There you go, Janace. Hopefully that helped. Let me know if you have another question. From Carrie, have you noticed if embolization before immunotherapy helps make it work better for NETs? This Carrie has a well-differentiated with Ki-67 of 25.
Yeah, so this is interesting. That's an interesting question. So immunotherapy is, and the question was embolization and immunotherapy. Was it?
Sorry, it was... Have you noticed if embolization before immunotherapy helps?
Because immunotherapy is not used much in neuroendocrine tumors. Immunotherapy for well-differentiated neuroendocrine tumors does not work well. So less than 10% of tumors respond. Immunotherapy has a role in poorly differentiated neuroendocrine carcinomas, but that's where we don't use embolization very much. So, but the bigger question is, will embolization increase the efficacy of immunotherapy in general? And that actually might be, and has not been adequately studied in neuroendocrine patients. But there's this thought that if you give immunotherapy, you raise the aggressiveness of your immune system, you embolize a tumor, the tumor cells burst and release whatever is in them. Now the immune system can actually see the tumor cells and starts acting more decisively on them. So it's actually a fantastic research question, and it's actually being asked.
Yeah. And to call back to the person that talked about how Dr. Halfdanarson explained things like that, it's so good. That was very visual. I really like that. So I understand why people are responding very well to your answers. Marnie, follow up to the PNET question. Is there a maximum number of CAPTEM rounds you would consider to reduce tumor size?
This is a great question. 2 years ago, I said, no, we'll just keep going as long as tumors are shrinking, and the longest I've given it is 3 years. And but now there are some data, including from Memorial in New York and some from London, saying that the benefits beyond 9 to 12 months are probably not that great. Meaning, what I'm saying is that you get the most of the benefit in the first 9 to 12 months. Treating beyond that might keep things down, but it's probably not going to shrink them much. I continue to treat as long as there's a noticeable shrinkage from one scan to the next, but typically not much beyond the 12 months. But here is the really interesting thing, and this is also a work from Memorial, from Dr. Nitya Raj and Dr. Diane Reedy. And they've actually seen that some of the patients who have a good response to CAPTEM in the first 9 or 12 months, even after you stop the treatment, they continue to respond without therapy. I didn't really believe this, and until I saw my first one. A year after stopping CAPTEM, still the tumors were shrinking. So it's almost as if you set the tumors on this sort of almost like this path of self-destruction. And the chemotherapy is long gone, but the tumors are still actively dying as if the chemotherapy is still there. I don't know. I'm eagerly waiting for the next Memorial paper on this.
Got it. A couple more questions. This is a basic question from Bridget. What are the grades of NET tumors? And then she asked different treatments for them. That might be a little more, but let's start with the first one. What are the grades of NETs? Yeah, so this goes to the grade, the difference between grade and differentiation. These are closely related,
but very distinctively different terms. So tumor grade is essentially a way to assess how rapidly the tumor will grow. And the way we do it is by using a stain called tissue stain called KSH7. Think about it as like a stain or a paint or ink that we just stain the slides with, and it sticks to the cells that are actively growing. And so if it's 1%, then only 1% of the cells are actively sort of in the growing phase. The rest are just sitting there quietly and waiting and not doing anything. If the stain is 99%, that means that all of the tumor cells are actively growing. So the grades are 1, 2, and 3. So grade 1 is KSH7, 3% or less. Grade 2 is 3 to 20% KSH7, and grade 3 is more than 20%. But there's a huge difference between 21% and 99%, yet they are in the same grade. So that's when we look at the differentiation. That's how the cells actually look in the microscope to the pathologist. Are they all sort of well-behaving, look all the same size, shapes, or are they all like different sizes and shapes and they look angry and ugly and irritated? And that's the differentiation. And we have to interpret both. Grade is easy. Most people get that right. Differentiation is very, very tricky, even for great pathologists. So we have to look at those two things. Grades 1, 2, and 3 based on KSH7.
Got it. David asked again about the NET test, who the doctor was. This is a question for me. The doctor is Dr. Irvin Modlin, and that episode was on July 13th, 2020. I believe that we have already put that in the comments section on a link, but it's the first Luncheon with the Experts episode, so you don't even really need to filter through dates. Okay, from Marianne, do Sandostat injections have to be given exactly 28 days apart? Is efficacy reduced if given more than 48 hours early or late?
Not at all. So no, it doesn't make a difference one way or the other. You can give it a few days before or a week or two too late for most people. Where it gets a little tricky, if you give it shorter than 4 weeks, insurance might have issues with it because they are so used to pay for this every 4 weeks. So if you do like 3 weeks plus 6 days, you might actually get an angry call from them. Nothing, but you might just say, what are you doing there? And sometimes we explain, well, the person was just going on a trip or something and they just had to do this so they could go to that wedding. And then we just settled that. But in terms of efficacy, no difference.
Got you. Thank you. From Florian, our friend from Germany, good to see your name and face in the little avatar. Is there a reliable way to check histamine levels? I heard that it wouldn't be easy.
There is not. Histamine is a hard thing to check. Histamine is not that commonly elevated in neuroendocrine tumors. In some lung and some stomach neuroendocrine tumors, it may be elevated. It's a tricky test to do. We do it, but then histamine levels are increased in so many other disorders, like allergic disorders, what's called mast cell disorders. So an elevated histamine level may or may not be related to a neuroendocrine tumor in that person. It's a tricky test, can be done, but it's a tricky test to interpret.
Got it. Dr. Halfdanarson, we talked earlier about alpha therapy. Any other new treatments or studies that you're excited about that are in the near future?
Yeah, so probably the thing that is we're looking at now most actively is a drug called cabozantinib. And, so that's in a very large clinical trial run by a group called Alliance for Clinical Trials in Oncology. So we're seeing some nice activity in patients on that. So that's exciting. There are some early trials on PRRT combined with other medications, even possibly with immunotherapy. And then there are obviously, it's interesting to see where the NET test and the other markers, there might actually be other markers coming as well, similar to the NET test, see how they perform over time. But in terms of drug therapy, I'd say cabozantinib and the alpha particles are probably the most exciting things right now.
Good to hear. And folks, that is the hour. We are at the end of the show. Really great session, Marnie says. Thank you so much, Marnie. I totally agree. A lot of great questions today, too. So I want to turn that back on you, the audience. Really great job. I expect that from you. You all do such a great job.
And thanks to the Carcinoid Cancer Foundation and all of you for calling in, carving out an hour to watch this and participate. Very grateful for that.
I appreciate you saying that. It's a really great point. I'm impressed, Dr. Halfdanarson. Every week we have people from all over the world tuning in live. Now, watching the video is one thing. You can watch it at any time, but to be here live, sometimes it's midnight where people are at other parts of the world. So that's dedication. And so it also lets us know that we're doing our job well. And we appreciate you being here and helping us do that job well. So thanks again for being on the show.
Always happy to join.
Great to hear. And thanks again to you all at home. And we hope this program helped answer some of your questions. But I'll reiterate one final time. If it didn't, or if you have follow-up questions, reach out to Carcinoid Cancer Foundation, either here on the Facebook page or at carcinoid.org. Thanks again, as always, to our presenting sponsor, Ipsen Biopharmaceuticals. Without them, we couldn't do the show. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.
Bye-bye.